And when we talk about secondary prevention after an injury has occurred, what are we trying to prevent? Re-injury, right, reoccurrence, right. So primary prevention, we don't want them to be injured in the first place. Secondary prevention, we don't want them to be re-injured. What's a good example of something that we might commonly see that a person can be subject to re-injury? Common injury that makes a person subject to re-injury. Yeah. ACL tears, ankle sprains, right? Recurrent ankle sprains. You know that once someone has stretched a ligament, right, it tends to stay stretched and it may be subject to re-injury, right? So that would be secondary prevention. So primary and secondary prevention are a big reason, a big thing that we need to focus on. Obviously, we're focusing on restoring function, right? That's our main role. If we heal an injury and the person can't do more than they did when they started with us, we haven't accomplished very much. All right? And that's obviously a big part of what we do, what we need to be able to do. And that restoration of function sometimes, quite frankly, is more important than the impairment. Right? Because the person may be most interested, I'll give you a great example. There was a lady I was treating one time who had come to me with an impingement syndrome in the shoulder. And she had pain, that was her primary sign. She had pain when she was vacuuming the house. That's what finally brought her to the doctor. She had pain when she vacuumed. After treating her for several weeks, she felt like she wasn't really getting any better. And she said, yeah, I don't really feel like I'm getting anywhere. So I said to her, when was the last time you vacuumed the house? I said, this morning. How did it go? She stopped for a minute and said, I had no pain. That's progress, right? And it totally changed her perception of how things were going. She was basically at the point of giving up because she felt like she wasn't better, because she could still make her shoulder hurt. Well, our goal wasn't necessarily to completely eliminate that pain, because we may not be able to. But if the function is restored and the pain is manageable, well, then that's a successful outcome. And it's very different than the way a surgeon may look at it or other medical professionals may look at it. Okay, we're looking at the function. And also, we can perhaps not just rehabilitate someone, but actually improve their performance to promote optimal performance, right? Could we work with someone to improve their golf swing?
Oh, yeah. Oh, yeah.
Could we work with someone to improve their pitching ability?
Yeah.
How about just their lifting ability?
Yeah. Technique.
They don't have to just be an athlete, right? Getting in and out of a truck, getting in and out of bed, right? So not just normal ADLs, but functional activities. Somebody is a truck driver, they're not stepping up a step like this, right? They're probably stepping up about to here. A lot more difficult than going up a regular step, but it's still something we'd work on, right? When we look at kinesiology, there's two main things that we're looking at. Kinetics, right, which is just looking at forces that either act on the body or are produced by the body. Kinetics simply involves forces, okay? Kinematics is movement without regard to the force. So kinematics is primarily movement, kinetics is primarily forces, all right? And I've also mentioned forces that are produced or act on the body. What's a force that's always acting on the body? Gravity, right? So that force is constant. It's always acting on the body. We have to respond to that force in some way, normally or abnormally, okay? There's another word for those two types of forces acting on the body and forces produced by the body. Can you think of what word we might use to describe forces that are produced by actions of the body itself?
Intrinsic.
Intrinsic, exactly. So what's the opposite of intrinsic? Extrinsic. So an internal intrinsic force, an external extrinsic force. Gravity is not the only extrinsic force that acts on the body, but it's one of them. Okay? So we can break those forces down further. And we are, in PT, we're particularly concerned about these forces. Right? Also, when we talk about biomechanics, it's a little different than what we're doing here. Biomechanics is really looking at principles of actual mechanics and applying it to different activities performed by the human body. Okay? So biomechanics may be, again, we're looking at how someone is lifting, working at a computer station, okay, pushing or pulling some objects. Okay? We're looking at the mechanics of that. That's really not what our focus is going to be here. Our focus is going to be more on the structure and function and anatomy of the human body. That's really what we're going to be looking at. This is really not a biomechanics course. Kinesiology as a study really is both art and science, okay? Especially in what we do. You know that we have to understand what happens in pathology. We have to understand what happens in certain diseases and injuries, how it affects the body, but we also have to understand how it affects the mind, right? Is it common for someone to be afraid of re-injury when they've been injured doing something? Sure. And we have to manage that. We have to deal with that, okay? And there's an art to that. It's not just a science. You're going to see, we talk about this in professional issues next semester, your final course. The slogan for the APTA. What's the APTA?
That's our governing body.
What's the name of it? What does it stand for? Ah, come on. That's an easy one. I guess that's going to be your first test question. American Physical Therapy Association. Yeah, it's the association that represents physical therapy. Okay. But their slogan is, the science of healing, the art of caring. Right? We have to understand the science of how what happens in injury. But you could be the greatest scientist, and if your patient doesn't think that you care about them, you're not going to be effective. By the same token, you may be the most caring person in the world, but you haven't got the first clue of what happens in injury and disease processes. You need to be good at both. Okay? You need to be good at both. So kinesiology is really looking at the study of human movement. Clinical kinesiology, we're applying that knowledge to what we do in physical therapy. Okay? That's really our focus. Now, again, we talked about kinematics is movement, right? Kinetics is, we're looking at forces, and kinematics, we're looking at movement. We're looking particularly of two types of movement, osteokinematics and arthrokinematics. What's the difference? What does osteokinematics mean? What does osteo mean? Bone. So it's kinematics, movement. So osteokinematics is bone movement. What is arthrokinematics? Joint movement. Do the bones move differently than the joint surfaces? Sometimes yes, right? Yes. So we're going to distinguish. Our focus is a great deal is going to be on the arthrokinematics, but we have to understand the osteokinematics, how a bone moves, an entire bone moves during different functional movements. But particularly, and especially if you want to understand joint mobilization, you need to have a thorough understanding, intimate understanding of arthrokinematics. That's why you're going to spend so much time on that, and it's why it starts with today. We look at this articulated skeleton. We know that there are planes of motion that exist in humans, and they occur over multiple axes. When someone is moving in one plane, we refer to that as a cardinal plane motion, right? That is not how most humans move. But movement in one plane is considered a cardinal plane motion. And those three planes are the frontal, sagittal, and transverse planes. Okay? Those are our cardinal planes of motion, frontal, sagittal, and transverse. They occur along three different axes. Now, we're going to primarily focus, when we talk about an axis, if you look at this from the pure physics aspect of kinesiology, we have an X, Y, and a Z axis. We're not going to use X, Y, and Z. Okay? We're going to use medial lateral, superior inferior, and anterior posterior. Those are the clinical terms that we're going to use. So what axis corresponds to anterior posterior? The Z axis, right? So whenever we see, if you see Z in some reference or in some document, we're thinking AP, anterior posterior. And we understand, right, just like we can have movement in lots of different directions. We can move AP and we can move PA, right? From posterior to anterior, from anterior to posterior. So when you see, and when we use terminology, when we say an AP movement, we are moving from anterior to posterior. That's the direction. The axis is the AP axis. It could also be described as the PA axis, right? But if we're talking about a movement, we identify which direction we're moving. Follow? Lateral to medial or medial to lateral. They are both the medial lateral axis, but movement can be in either direction or both directions, right? So don't worry about the X, Y, and Z. Think of superior, inferior, anterior, posterior, and medial lateral axis, okay? When we name movements at these joints, again, this is review, we know this, but again, we're translating this now into our kinesiological terminology. Flexion, extension, and hyperextension, along with dorsiflexion and plantar flexion. These are occurring, these are cardinal plane movements, right? Abduction and adduction, also radial ulnar deviation and lateral deviation. These are cardinal plane movements. And then medial or internal and lateral or external rotation. Okay? These are also cardinal plane movements, as is supination, pronation, inversion, eversion. Now, when we start getting down to level of joint, we'll see there really are no cardinal plane movements in human beings, because a lot of our joint axes are oblique. Okay? So there really are no cardinal plane movements in the human body. We describe them. The terminology is described in a cardinal plane. In function, that is not how we move. It's not how the human body moves. Okay? If we look at osteokinematics, again, we're looking at the bones themselves through a range of motion. How that bone moves throughout a range of motion. Okay? Motion that occurs in this cardinal plane occurs around an axis. That axis is always perpendicular to the plane. The axis of motion is always perpendicular to the plane that motion is occurring in. Kinesiological terms. There's two types of motion. Transitory or linear motion. That's motion that is occurring in the same plane. The axis of motion is in the same plane of motion. So that is translatory or linear motion. This is an example of translatory or linear motion. Right? I'm staying in one plane. The axis of motion is in that same plane. Okay? Rotary motion or angular motion occurs around an axis. Okay? And that motion is parallel to the axis. Is perpendicular to that axis. That's rotary or angular motion. It's motion around an axis. And again, this would be an example of a rotary motion. As with this would be an example of a rotary motion. It's occurring around an axis. And that axis is perpendicular to the plane that I'm moving in. That's our kinesiological terminology that we need to think in. All right? We also know that there's 3 degrees of freedom available, maximum, when we're looking at motion. If motion is occurring in one plane, it's 1 degree of motion. Okay? So it's the number of axes that motion is occurring about will determine 1, 2, or 3 degrees of freedom. How many axes of motion are occurring? Okay? How many axes do you think are occurring in this motion? How many axes of motion are we seeing here? 3. Or any rotary motion in the human being. Okay? And this in particular, when we get to the wrist and hand, you'll understand this is really not a pure rotary motion. There are 3 individual motions that are occurring. And when we start looking at the structure of the joints, we'll see why that is the case. Okay? We have, again, 3 degrees of freedom in the unilateral unilateral motion, that we'll see that's associated with a hinge or a pivot joint. A biaxial motion we'll see in a condyloid, ellipsoid, and a saddle joint. Okay, these are what we classify our joint shapes. Triaxial motion, primarily in a ball and socket joint. Okay, so we're moving around 3 axes of motion. We would need to have a ball and socket joint for that to truly occur. This motion is not occurring at a ball and socket joint. And again, when we get to the wrist and hand, we'll see why that is the case. This certainly is a ball and socket joint, glenohumeral joint, as is the femoral acetabular joint. Okay? And again, what we'll always emphasize, we start naming things in the human body. You name a joint by the bones that comprise that joint. And we're going to be very particular about that. This is not the shoulder joint. This is the shoulder region. Okay? This is not the hip joint. This is the hip region. How do I name this joint? I just did. Femoral acetabular joint. Right? Yes?
Can you reverse that?
Acetabular femoral is fine. But we're naming the bones that make up that joint. You can do it the other way around. Glenohumeral or humeral gleno. Humeral glenoid. Okay? Reason I mention that, when you start having conversations, especially with surgeons, which we will sometimes do, if you get confused and you use lay terms, if you're not talking to the right surgeon, they will rip your head off. I remember being at a grand rounds meeting one time at St. Joe's Medical Center up in Patterson, and there was a presentation by one of the most renowned hip surgeons in the United States. He actually was one of the people that developed the total hip replacement surgery. His name was John Bromley. And he was up there doing his presentation, and there were a bunch of people in the room this size. A lot of them were orthopedic residents, so orthopedic surgeons in training. Right? And one of the residents raised his hand, and after Dr. Bromley said, the most common fracture that is responsible for hip replacement is a proximal femoral fracture, right? Hand goes up. Yes, this orthopedic resident said, but I thought the most common fracture was a hip fracture. And so Dr. Bromley did this. Where's the hip? He went, oh, that's the femur. Yeah. Mm-hmm. So, needless to say, that was a little embarrassing for that orthopedic resident. And he was the chief resident. That was really scary. So again, we want to use proper terminology. It's very sloppy and frankly just wrong to talk about the hip, the shoulder. We're talking about a joint. Name the joint, right? Is there only one joint in the shoulder complex? No. No, there's not. And if I told you to perform a joint mobilization to the shoulder, have I really told you anything?
Nope.
Well, what I've told you is do joint mobilization to every joint in the shoulder complex. That's what that would mean to me. Is that really what we want to do? And any movement in all directions? I don't think so. Right? Okay. We assess joint motion with goniometry. Right? We're measuring rotary motion. That's where we get an angle. Right? Clinical goniometry is how we assess joint motion, how we measure joint motion. You know this. We also assess joint by end field. Right? There's normal and abnormal end fields depending on the joint, depending on the structure that we're stressing. Right? We have soft, hard, or firm, empty end field, which in most cases is abnormal. Not all cases, but most cases indicate some pathology. All right? So we're assessing motion, we're assessing the what we actually feel when we move the joint around. All right? That's when we're looking at joint play. As I said, that's going to be a focus of a lot of what we do in this course. What's our time?
927.
927?
Yeah.
Okay, good, thank you. All right, so we're assessing joints in different ways, right? We assess it through goniometry. We also assess it in terms of feel. We're assessing joint play, what we're feeling as we move that joint. I would say manipulate that joint, as we move that joint. Okay, again, when we look at kinematics of the joints, we look at a chain of movement. Okay, we're looking at a chain in the human being. You don't just move one joint in order to function, right? How many joints are moving when I do this? A lot. A lot. Almost every joint of my body as I'm doing this, including the fact that I'm talking as I'm doing it. Because that involves my TMJ. All right? So movement is occurring over multiple joints, functional movement. All right? But we can break down, when we look at that chain of movement, kinematic chain, we can see that there's two basic kinds of movement. Movement that is occurring in an open kinematic chain or a closed kinematic chain. As I'm walking across the stage, which chain of movement is occurring? Both. Yeah, exactly. Both. And alternating, right? If I'm stationary, what kind of movement is this? People are a little unsure, but I hear most people saying closed, right? Why is it closed? The definition, and this is where people are going to get confused, and you will get confused if you don't focus on this definition. In an open kinematic chain, the distal segment is free to move in space. This is an open kinematic chain. This is a closed kinematic chain. I'm fixing the distal segment. Don't think of it in any other way or you will get confused. Yes?
So, I was looking at like closed chain, open chain, and then also compared to the closed and open with the kinematic in between. Is there a difference or is it the same thing? Because online they use interchangeably, so closed kinematic and closed chain.
Oh, yeah, no, that's closed kinematic and closed chain. Yeah, same thing.
Okay.
They're just eliminating the word kinematic. Yeah, they mean the same thing. Open chain is the same as open kinematic chain, right? But it's a less clinical term.
Right, and that's why they
Right.
use it. Okay.
Right. It's a less clinical term. And it depends on what literature you're looking at. You might see open chain,
Right.
okay? But that's what they're referring to. They're referring to the kinematic chain. But as I said, don't get confused by this, okay? How about pedaling a bicycle?
Close.
Has to be, right?
Yeah.
Because that distal segment's fixed. Isn't the proximal segment fixed?
Yeah, if you're seated.
Because you're sitting on a seat, right? Sitting on a seat. It's a little questionable how you would really define that. But, again, is the distal segment free to move? No. So we would have to define that as a closed kinematic chain activity. And even more so, everybody familiar with the difference between a toe clip and a toe cleat
Yeah.
on a bicycle?
Yeah.
A toe clip you slide your foot into. A toe clip, it's attached to your shoe, and the shoe is then attached to the pedal. That is a real closed kinematic chain. There is no movement of that distal segment at all. Whereas in a toe clip, I might be able to lift the foot. I might be plantar flex and dorsiflex. Why do we even use toe clips or toe cleats? Anybody know? Why?
Well, because you can use 3 different muscles to pedal your bike.
Think about it from a purely kinesiological perspective.
To generate more force
How do we generate more force?
by pushing down into the closed chain
And somebody said
Pulling.
pulling. You can push the pedal and pull the pedal when your foot is fixed to the pedal. You have no clip or cleat. You lift your foot off the pedal stays there. Your foot lifts up. So you're able to increase the efficiency of that stroke, increase the amount of force that's being exerted because you're able to push and pull. That's why they use toe clips and toe cleats. They're not just pushing down on the pedal, they're pushing and lifting, pushing and lifting, pushing and lifting. As we push on one, we lift on the other, all right? But that would really be a closed chain activity, because that foot is fixed on that pedal, okay? But again, make sure that you think of it that way when you're differentiating between open and closed kinematic chain. The distal segment is fixed in a closed kinematic chain, okay? Again, when we look at arthrokinematics of a joint, we have, as we said, to understand anything in the body, you got to start with the anatomy. The anatomy of the bone, the anatomy of the joints is determined primarily by the morphology or the arthrology of that joint, the shape of the bone surfaces, right? That determines what movement is going to occur primarily. It's going to start with the arthrology and the arthrology of the joint, classifying the joint by their shape. Okay, and that's determined by the shape of the bones that comprise that joint, particularly the bony surfaces, the articular surfaces. And we have three basic types of joints: a symarthrosis, an amphiarthrosis, and a diarthrosis, or diarthroses, plural. SIS singular, SES plural. Okay? In synarthroidal joints, they have primarily a fibrous structure. Okay? There's a lot of fibrous material that allows for stability of that joint and allows some mobility. Okay? As synarthroidal joints, primarily the fibrous structure is the predominant feature. And those joints are between bony segments. Okay? And those joint surfaces are very congruent, meaning they have complementary shapes. Okay? If I'm curved on this side, I'm curved in the opposite direction, a convex and a concave. And it's a very congruent joint. There's a lot of contact between the two bony surfaces of that joint. That's what we mean by congruent. Okay? Very congruent joint. And it's very tight because of the fibrous structure of those joints. And there's two subtypes of those synarthroidal joints: the syndesmosis and the gomphosis. Okay? What's a good example? You know, one of the more common syndesmoses in the human body? I shouldn't say one of the more common. Probably one of the ones that you would first think of.
The sutures in the skull. The sutures in the skull.
Sutures in the skull, yeah. That's very, very congruent, right? The pubic symphysis, yeah, exactly. Exactly. Those are two very common examples, right? So the sutures of the skull, again, very congruent, like a jigsaw puzzle, right? But that's a very congruent joint in this fibrous structure holding those joints together. So much so that we don't even consider them joints in the adult, depending on who you talk to. We won't get into that. We will not get into that, okay? If we look at the amphiarthroidal joints, okay, they are primarily responsible for allowing both movement and stability. Kind of a dual-purpose joint, where a synarthroidal joint is primarily designed to provide stability between bones. The amphiarthroidal joint is meant to provide both stability and mobility. Okay? In order to create stability, one of the hallmarks of these types of joints is the presence of cartilaginous structures between the bones. Okay? Good example of this are the intervertebral joints of the spine and the pubic symphysis, because, I know we mentioned the pubic symphysis before, there is a cartilage between both halves of the pubis, the left and right. There is a cartilaginous disc in there, which would really make it more appropriate to describe it as an amphiarthroidal joint. Okay? So it's the presence of that cartilage that really distinguishes the amphiarthroidal from the synarthroidal. Okay? The diarthroidal joints, so we're moving from more stability to more mobility. The diarthroidal joints are the joints that are primarily designed for a great deal of mobility. Not a lot of stability, but a great deal of mobility. And those are going to be the major large joints that we see in the body. All right? And it's the most common joint that we're going to see in the body, because most of our joints are designed for movement. They are necessary for movement. their structure requires, or their function requires destruction, that allows movement. Okay? They may be either ovoid or cellular in shape. Cellular may be similar to a boat. Okay? And most are synovial joints. Most have a synovial lining. Okay? They create, because of the shape that we see of these joints, we can apply that concave convex principle to our diarthroidal joints. As one surface moves, depends on the osteokinematics of that joint. You know, the osteokinematics affect the arthrokinematics of that joint. Because we have a convex moving on a concave, or vice versa. Everybody remembers that one. Okay. Again, the hallmarks I've already mentioned, they have a synovial lining. They have synovium. They generally will have, the most common elements are cartilage, ligament, articular disc, a joint capsule, and bursae, along with that synovial fluid, the synovial lining. Okay? Anybody remember what the most common, or the primary substance that makes up synovial fluid? Ooh, maybe I'll make that an extra point question. Okay? What is synovial fluid comprised of? Look that up in your spare time. And I'll ask this. What should we not see in synovial fluid?
Blood?
Blood. Why not?
It's not what it
So
constitutes.
it's not one of the normal components of synovial fluid, obviously. There shouldn't be blood in synovial fluid. And if there is blood in synovial fluid, what does that indicate to us? Some pathology exists because there's been bleeding into that joint. Okay? What's the one of the more common injuries where we see that occur? You mentioned it already. Common injury in athletes. ACL tear. ACL tear. And when we get to looking at the knee in more depth, you'll understand why that's the case. Has anybody ever had an ACL tear? Wow, nobody. I think you're the first class in years that no one has had an ACL tear.
Way to go, guys.
Yeah, you got something going for you. Congratulations. Okay. Again, the basic arthrokinematics of joint motions, again, we see rolling, gliding, or sliding. Those terms can be used interchangeably. Rolling is associated with a rotary motion, right? Gliding or sliding really is a translatory motion. Again, this would be sliding or gliding. If I turn this bottle on its side, it would be rolling. Okay? I know that sounds obvious to you, but you want to be able to visualize these things whenever you see the term. Also, spinning, okay? Motion is occurring along the long axis of the structure. That would be spinning. This is the long axis of the structure, all right? And distraction and compression, right? Is gravity responsible for compression or distraction?
If you're upside down, distraction.
Is that the only way distraction occurs, if I'm hanging from a bar?
No.
Aren't both forces being exerted on my body right now?
In multiple directions. Yes.
Give me an example of where distraction is occurring. Glenohumeral joint. Exactly. Right? It's hanging free in air. Gravity is tending to distract my glenohumeral joint. So they're both occurring. Gravity creates compression and distraction. Depends on the joint. I know you said it depends. Yes, it depends. That's absolutely true. But even in the normal anatomical position, which you know is this, right? So again, keep that in mind when we start talking about motions. We're talking about motion that is occurring from the anatomical position. This is the anatomical position. This is not. keep that in mind, otherwise you'll get confused when you look at some questions. Okay? We have, when you look at, if you start looking at any literature that talks about joint mobilization, have any of you seen the term physiological and accessory motion? Have you seen that or heard that talked about in the clinic?
I just got railed on yesterday.
Good, then you know the answer. What is physiological motion?
It's like a voluntary movement, some like flexion, extension, and adduction.
And it's movement that you produce with your own force, right? It's normal, functional, anatomical motion, physiological motion. What is accessory motion?
Like an ancillary, it happens as a result of that. It's the upper kinematics.
Right, so it is associated with that anatomical motion, and we could perform that accessory motion without any force being applied internally, any intrinsic force by the body. That's a long way of saying we can mobilize a joint. We can apply an external force and cause accessory motion to occur that the person could not generate with their own muscular force, right? I can't, with my muscular force, distract the glenohumeral joint without using the other limb, right? Just with my arm hanging at the side, I cannot voluntarily distract this joint without applying some external force, all right? That's joint mobilization and manipulation, right? That's the definition of joint mobilization. We're applying an external force to cause accessory motion to occur that the person cannot generate on their own with their own muscular force. So it's a long-winded way of describing joint mobilization. But you want to be able to distinguish between physiological and accessory motion. You have to have the accessory motion in order for that physiological or anatomical motion to occur. Without the accessory motion, the physiological motion will not be normal, right? Because the joint surfaces are not moving as they should. Yeah.
Would it be right to say that accessory motion happens, so like the gliding and sliding and the kinematics happen with flexion?
Needs to happen. It needs to happen, right?
So accessory motion is a byproduct of physiological.
It's a component of it, right? It's really the other way around. The physiological motion occurs because of the accessory motion. If that accessory motion is impaired or limited, we can't have normal physiological or anatomical motion. That's why we work on joint mobilization, right? If the patella is not sliding in the patellar groove, am I going to be able to get normal and full knee flexion and extension? No, because it's being limited by that loss of accessory motion of the patella. And I can work on that motion of the patella, right? What am I saying, accessory motion? Can I, with my own force, laterally distract my patella? No, but I could do it with an external force, right? So that's how we distinguish, again, between that and why it's so important to understand the role of accessory motion, okay? And again, the aspect of it, the fact that it's involuntary, you're not controlling that accessory motion. Yes?
So an accessory motion could occur if a therapist were providing the physiological movement of the force.
Yes. And a therapist we can manually create physiological or anatomical movement. That's passive range motion, right? We can create that movement. We can also, through application of external force, create an accessory motion, right? We could do both. A person with their own muscular force cannot produce an isolated accessory motion of a joint. Isolated, right? It can't just cause a roll and a glide without the physiological motion occurring. Get it?
Yeah.
So that's why that accessory motion in normal function is a component of the physiological motion. It's necessary in order for that physiological motion to occur. Where are we time-wise?
9:47.
Okay, let's quit there. So we'll pick up on Monday when we start looking at the joint shapes. And again, revisit that convex-concave rule. Yeah?
You said everything that we're talking about is on Moodle?
Yes. Yep. Your presentation is on Moodle. This PowerPoint is on Moodle. This printed PowerPoint. And the references are in your Moodle room. Obviously, you can't access it if your registration hasn't gone through yet. So hopefully we get your registration sorted out today. I know Dr. D'Onofrio is going to be addressing that today. And which brings me, before we break, labs. Okay? You need to be broken up. So is Stephen here?
Yeah.
Oh, where area? Okay. You're going to come to both lab as well?
Yeah.
Okay. So there should be 20 of us. 2, 4, 6, 8, 10, 12, 14, 16, 18, 19. Who are we missing? Somebody's missing. 2, 4, 6, 8, 10, 12, 14, 16, 18. So I'm missing some.
Where's
Who's missing?
Melissa.
No, Melissa shouldn't be here. Wait a second. Let me get my right. Sound off. Andre.
Oh, what's up?
Andre's here, yes. Chris Birchler.
Here.
Monica's here. Isaiah. Cindy's not here. Cindy? Oh, there she is. Richard. Dan.
Yeah.
Kyle.
Here.
Andrew.
Here.
Devin.
Here.
Jasmine. David's here. Rod Neal's here. Casey's here. Joe.
Here.
Ashka. Chris Spencer.
Here.
Jade. Brian.
Brian, yeah.
I don't think you counted Brian.
Yeah, I think the first run around, you didn't count Brian.
Well, no, I'm reading off my list. Okay, did I not count you? That's
Oh,
right.
okay.
You don't count.
That's
You don't
trying to
count.
sneak under the radar. Yeah.
No, so what I was going to say is what we're going to do with labs, because you guys, this is your, in case you didn't know, this is your worst semester. This is your busiest semester. This is your busiest semester, okay? The way labs are going to work, I need 10 people in each lab section for kines, okay? One lab is right after this class from 10 to 11:20. The next lab is 11:30 to 12:50. At the same time that you are having lab 2 in this class, lab 1 in 201 is going to be occurring, okay? So we obviously can't be in two places at the same time. What Dr. D'Onofrio and I have agreed to do is, as long as all of you get both labs done, he is agreeing. I don't know if he's talked to you about this already, because you have a late lab on Monday and Wednesday.
He had mentioned it, but it was kind of tough on the Zoom.
Okay. If you're in lab 2 for PTA 201, you're either in lab 2 or lab 1. He's going to allow you to flip every other week so that you're not here late every single week. When you flip his lab, you got to flip my lab. Remember, if you're in lab 1 here, you've got to be in lab 1.